Good evening to everyone. First, I would like to thank the Davao Society of Ophthalmology for the invitation to give a talk about the role of anti-VEGF in ROP management. Davao is a special place because it is the location of the first major project of the ROP working group with the Apple the App Foundation for the REDCAM project, which continues up to this day. So, to start, this is my financial disclosure. I do receive honorarium for anti-VEGF lecture that I give on behalf of Novartis and Bayer. This is the outline of our lecture today. Let's discuss first the evidence and the rationale for anti-VEGF in RO. Peripheral retinal ablation remains to be the standard of care in the treatment of type 1 ROP. However, infants with the most immature retinal vasculature have the greatest risk for ROP, resulting in blindness, even with laser treatment. Accepted therapies are not always effective in preserving the retinal architecture and visual function. There are poor outcomes in Zone 1 seen in the clinical trials. We have 87% in cryo-ROP and 30% in ETR. The following are the complications of laser treatment. So these are most commonly seen in Zone 1 or in aggressive ROP. The post-laser treatment can look like this. Then, as always, in the spirit of progress, doctors started asking, can we do better than this? Since 2007, anti-VEGF has been looked upon as an alternative treatment due to the following reasons. In 2011, the BEAT-ROP was published. In this study, infants were randomized to bilateral laser or bilateral bevacizumab. It tested for the efficacy of intravitreal bevacizumab for stage 3 plus ROP in zone 1 or in posterior zone 2. The results of BEAT ROP supported anti-VEGF treatment, but it is an efficacy study and not powered to study the safety. The BEAT ROP study opened the doors for similar RCTs, so that in 2017, the AAO published its Ophthalmic Technology Assessment Report. Its purpose is to review the available evidence on the ocular safety and efficacy of anti-VEGF for the treatment of ROP, as compared with the laser. The report concluded that anti-VEGF has short-term efficacy and the ocular safety are similar to laser therapy. With respect to the severity of ROP, there seems to be several potential advantages for primary treatment with anti-VEGF for eyes with zone 1 ROP or eyes with aggressive posterior ROP. However, there's no clear advantage over laser photocoagulation for eyes with more peripheral zone 2 ROP. Although treatment of zone 1 eyes with anti-VEGF treatment can allow some retinal vascular development over time, most zone 1 eyes treated with anti-VEGF will never completely vascularize and may still need retreatment after 55 weeks post-menstrual age. There is a growing trend towards treating with anti-VEGF worldwide. So listed here are the advantages of using anti-VEGF agents, which include less time to administer the treatment, faster improvement in the plasticity and regression of ROP. We can see less treatment-related destruction of the peripheral retina, and there is lower likelihood of myopia. Now, the concerns of using anti-VEGF drugs in premature infants will be discussed. So now that we know that anti-VEGF is effective based on the studies published, the next question is intravitreal anti-VEGF safe in preterm infants? So in 2012, Raynaud, in an article in the New England Journal of Medicine accompanying the BEAT ROP publication, stated that it seems reasonable to assume that intravitreal bevacizumab is safe, but our pediatrician colleagues are very worried because in neonatology, we have many examples of therapies being adopted because of short-term benefit ahead of proper studies. The examples of which are the uncontrolled oxygen, which actually brought about the first ROP epidemic, and other examples like your interferon for capillary hemangioma and other cases like that. So we have to remember that the absence of evidence of harm is not an evidence of no harm. These are the 4 areas of concern in using anti-VEGF in premature infants. We will discuss this one by one. VEGF inhibition of developing neural retina. There's very minimal published research in the toxic effect of anti-VEGF in the neural retina. In this report by Kong, which involved a single infant histopathology report of bevacizumab in ROP, it has shown that bevacizumab was well tolerated without any signs of toxic effects. In particular, there's no inflammation, degeneration, or necrosis observed. Furthermore, the results show that bevacizumab effectively controlled the neovascularization in zone 1, stage 2, plus ROP. However, a more recent study using mice with oxygen-induced retinopathy had shown short-term and long-term effects. Evidences on this are still conflicting. Hence, we should really be careful in patient selection for anti-VEGF treatment, especially those with anti-VEGF repeated injection. The second major issue is the effect of anti-VEGF in the normal vasculogenesis and angiogenesis. This study by Luti showed that the VEGF trap inhibited the formation of neovascularization of the retina when injected at postnatal day 8. In contrast, the lowest dose tested effectively blocked the neovascularization and caused regression of existing neovascularization without affecting vasculogenesis or retinal revascularization. These findings suggest that dose selection is an important variable when considering the use of VEGF targeting agents in the treatment of ROP. Fluorescein angiogram studies have been done on our post-injection patient, and it has demonstrated that there are actually abnormal angiographic vascular features that are found before and after anti-VEGF. So this published work shows abnormalities at 9 months and even up to 4 years after injection. So we can see here loss of capillary bed, presence of abnormal vascular branching, and presence of shunt vessels. Among the 20 bevacizumab-treated eyes available at 4 years of age, they all showed abnormalities of the retinal periphery. You can see here vascular areas. You can see here active vascular leakage. You can see also shunts, formation of shunts, abnormal vessel branching, and tangles of the posterior pole. These lesions are not observed in the majority of lasered eyes. These are additional photograph. So you can see here in the black circles, you have persistent avascular retina. White arrows shows capillary tufts, and the black arrows shows peripheral shunting as compared to ROP patient treated with laser. After 4 years, these features are not present on lasered eyes. The presence of your retinal capillary obliteration can also be found in vascularized retina as shown in these photographs. So even though the retina vascularized in that area, the retinal capillary is obliterated in those areas. So these are the things that we should watch out for. In contrast, studies presented by Mansukhani et al. Shows that the fluorescein angiography in ROP comparing infants treated with bevacizumab and those with spontaneous ROP regression, they say that these abnormal vascular patterns are also seen in patients who had spontaneous ROP regression. So claiming that maybe these findings are from ROP itself and not solely because of the anti-VEGF. The issue of persistent avascular retina has been a very common finding. So much so that the ICROP has included the definition of this finding in the newest update. So persistent avascular retina is incomplete vascularization of the retina. So persistent avascular retina may occur in either the periphery or even in the posterior retina. Compared compared with peripheral PAR, after spontaneous regression, the persistent avascular retina after anti-VEGF agent seems to occur more in greater frequency and actually involve a larger area. So that your persistent avascular area should be described by its location. Moving on to the next issue about your anti-VEGF is the question about systemic side effect. Because if we are asked if does intravitreal anti-VEGF escape to the systemic circulation, the answer is yes, it does. This study by Sato shows the time course of serum level of bevacizumab in infants with ROP. So the x-axis shows the time before and after injection, and the y-axis shows the serum level of bevacizumab. It shows that the levels of bevacizumab in the serum increases up to almost 1,300 nanograms per ml in 2 weeks. While the right side of the graph, it shows the time course of serum level of VEGF in infants with ROP who receive intravitreal bevacizumab. The x-axis represents the time before and after injection, and the y-axis represents the serum VEGF. It shows that the serum VEGF drastically drops to below 500 and continuously becomes less in the succeeding 2 weeks. This report shows that plasma VEGF falls to almost zero at day 1 and recover by 1 week in this study by Zhu et al. So these are other studies by different groups regarding the systemic absorption of your anti-VEGF. This is the result of the Rainbow study regarding the systemic VEGF levels. It shows that serum ranibizumab levels decayed from peak levels immediately after baseline to much lower levels after 28 days. However, the plasma VEGF levels were variable and there is no clear evidence of plasma VEGF suppression or of differences between the 3 treatment groups. So with regards to your systemic absorption, we have really many unanswered questions about the long-term safety of these drugs, and we are still needing more prospective safety clinical trials. Because although we are fighting against VEGF in the eye, VEGF is actually the Swiss army of vasoactive factors. So it regulates normal angiogenesis in many organs and has many roles in the body with the CNS development, lung development. So we need VEGF for the developing baby. More recent publication of a meta-analysis study shows that the risk of severe neurodevelopmental impairment was not increased after intravitreal bevacizumab treatment. This suggests that the risk for a severe neurodevelopmental impairment after IVB treatment is low. So further randomized trials are warranted to provide higher quality of evidence. The next concern about your use of anti-VEGF in ROP is about reactivation. So the reported recurrence rate is between 5 to 87% depending on the study. So this is a very important issue because progression to detachment can occur because of reactivation. And the pattern of reactivation maybe not so distinct so that it is very hard to recognize. And then the timing of progression may be altered as compared to laser treatment. In the BEAT ROP, time to recurrence with laser is only up to 6 to 7 weeks post the treatment. However, in using anti-VEGF, reactivation or recurrence can occur in 14 to 20 weeks after bevacizumab. So it means longer follow-up time whenever we decide to use anti-VEGF in ROP. ICROP3, the newest update on the nomenclature of ROP, has included reactivation, the definition of reactivation in its report. So they say that reactivation is more frequently seen after anti-VEGF treatment as compared to spontaneous regression. And it is very rare if you do a complete laser photocoagulation. According to the ICROP3, it's more commonly occurring between 37 to 60 weeks post-conception age. And here are the vascular changes that you should look for, which means your reactivation. So for reactivation, it typically occurs at the site of the original ridge. So like this one, this is the original ridge. Reactivation can occur at that site. Or it can also happen at the new leading edge, which means for this example, this site. Or it can occur at both sides, the original or the new leading edge. So these are where we should look for reactivation sites. So the risk of reactivation and progression to retinal detachment is uncertain because of your publication bias. So as of now, we really do not have the numbers or the reports for these percentages. So recurrence, maybe the problem with your recurrence or reactivation is that it may not be detected earlier due to the difficulty of examining the peripheral retina as the child grows older. So these are reactivation rate estimations based on different reports. So according to the University of Chicago, so they have about 50% recurrence or reactivation in APROP. And that is about 16% for all ROP. So you actually have higher reactivation rates if it is APROP. You have this reactivation actually shows as a leak or persistent avascular retina on FE in 91% of the recurrences. The influence of zone on reactivation. What we have to remember is the more posterior the disease, you have a higher risk of reactivation based on these reports. So much so that it is more likely to happen if you have an aggressive posterior ROP baby. The choice of anti-VEGF would also affect your reactivation rate. So based on several studies published, they say that ranibizumab will have a higher recurrence rate because of the half-life of the medication. So this is reported by Dr. Mintz-Hittner based on the BEAT ROP study. They have a recurrence incidence of 8.3 infants or 7.2% eyes. So the risk factors for your recurrence is an appearance of neovascularization as APROP. You have an extended growth or you have an extended duration of hospitalization and patients with lower birth weight. The period wherein most recurrences happen in the BEAT ROP is in 45 to 55 weeks with a mean of 51.2 weeks. So after discussing the issues concerning anti-VEGF, so we will now discuss how we can apply this principle or this knowledge in our everyday setting. These are the indications for ROP treatment. So this is based on the cryo-ROP, the ET-ROP. So you have your type 1 ROP and your aggressive posterior ROP. So in considering which to choose, like are we going to do laser treatment or anti-VEGF treatment? So with regards to the type of therapeutic intervention, there is no universally valid recommendation that can be made on the choice between laser and anti-VEGF. We still do not have guidelines. So the Philippines doesn't have guidelines at this moment. So we must consider each individual case. So you have to consider the advantages and disadvantages of the two treatment option, you need to weigh this taking into account the situation of your individual patient. So one thing that you can use to decide is on which treatment modality to use is that based on the results of the clinical study. So based on the clinical studies, those who responds better with your anti-VEGF are your aggressive ROP and your zone 1 and zone 2 posterior ROP. So for these cases, it is more commonly used or more commonly accepted to use anti-VEGF. If it is a treatment requiring zone 2, it's much better to use laser. So these are the anti-VEGF medications available in the Philippines. Among the three, ranibizumab is currently the only drug which is Philippine FDA approved for the treatment of ROP. So bevacizumab is also commonly used. However, ocular use and for ROP purposes remains to be off-label. This aspect needs to be taken into account in the informed consent process. There is also evidence of efficacy of other VEGF inhibitors such as aflibercept. However, the results of a larger prospective study like the Firefly study are still pending. So we have other smaller case series that have been reported, but the aforementioned studies provide the highest level of evidence for their effect. So what dose? Ranibizumab is approved for the treatment of ROP at a dose of 0.2 milligrams in 0.02 ml. So that is actually equivalent to 40% of the adult dose, which proved effective in the Rainbow and the CARE ROP study. Bevacizumab has traditionally been used at the dose of 0.625 milligrams in 0.025 ml. So that is actually 50% of the adult dose to treat ROP, the studies reported. So the dose is very important because for the beat ROP, they use 1/2 the adult dose. However, we have to consider that the body of an infant is actually 1/50th of an adult. And then the vitreous volume is only 1.6 as compared to 4.0 ml of the adult. And also the retinal surface area, infant is not actually half of that an adult, and also the blood volume. The dose of anti-VEGF is very important because it may contribute to local and systemic toxicity and long-term cognitive and neurodevelopmental outcomes. We must always remember that doses higher than 0.625 milligrams bevacizumab or 0.20 milligrams ranibizumab should not be used in order to avoid increasing the potential risk of adverse systemic effects. With regards to the intravitreal injection best practice according to SAFER ROP study, these are the best practice recommendations for intravitreal injection. So the acronym SAFER means S for short needle. It's recommended to use a 32 gauge 4.0 millimeter Steriject needle. For A for antiseptic, so we have to use betadine as an antiseptic, and then the follow-up period is very important. That's 2 to 7 days post-injection. And E stands for extra attention to detail. So that's maintaining a clean environment, assessing for conjunctivitis and nasolacrimal duct obstruction, and the area of safe injection site, which is actually 0.75 to 1 millimeter posterior to the limbus, using the aura nomogram. And then also R for recheck. Recheck or follow up after 1 to 2 weeks post-injection until mature vascularization is complete. These are also recommended to use a fluorescein angiogram to monitor the patient between 60 to 65 weeks if not fully vascularized, and to do laser if there are large areas of retinal vascularization. These are the recommended post-anti-VEGF follow-up. So first exam is 1 to 2 days after. Second examination is 5 to 7 days. And these are your subsequent examinations depending if you see partial or complete disease regression. What you have to do is to monitor for disease reactivation. Okay, so you have to do weekly for 4 weeks, 2 weeks, 2 weekly for further 12 weeks, and 4 weekly for further 8 weeks for a total of 28 weeks. So for patients with aggressive ROP, it's recommended to follow up to 32 weeks post-injection. So these are your table for the follow-up and what to specifically examine during that follow-up. Okay, so in these weeks, we have to look for reactivation of ROP in the form of plus disease or neovascularization. So follow-up means you have long-term to assessment of, you have to do long-term assessment of our patient with regards to visual functions, strabismus, cycloplegic, and retinal evaluation. So when to do examination under anesthesia post anti-VEGF. Okay? And then when you do your examination under anesthesia, it's also good if you also prepare to do laser. Okay, so when to do laser is that if the retina has not fully vascularized or you're not really certain about the status of the vascularity of the retina. And if the regular follow-up is becoming unsustainable because of social or geographic reasons, and you have problem examining the child because of the child is growing and you now have limited cooperation, which makes the examination of the periphery harder. And if you have uncertainty regarding the presence of signs of disease reactivation, and during long-term follow-up, there is really a significant area of persistent avascular retina. It's really very helpful if you have fluorescein angiogram in your facility. So what do you do? What treatment would you give if you have an ROP reactivation after your ROP injection? So what you can do, you have a choice. Either you do a repeat anti-VEGF or you do a laser treatment. So laser is preferred if you have potential difficulties with frequent follow-up, you have a risk of requirement for further repeated injection, and you have a risk of persistent avascular retina. You should avoid doing anti-VEGF injection if you have signs of fibrosis, and only if you see failure of progression of the normal vascularization. So this is what you should see, or what you should look for if the ROP of the child requires retreatment. So you have to classify first, is this patient insufficient regression or is this ROP reactivation? Okay. So if this is insufficient regression, which means there is persistence of plus or neovascularization, you should perform a secondary treatment. And your secondary treatment, again, you can choose either you repeat your anti-VEGF or you can do laser. However, you have to know you should not do repeat anti-VEGF injection within 28 days of your previous injection. If it's ROP reactivation, meaning you have a recurrence of your ROP, so you have the presence again of your plus or pre-plus with accelerating disease, meaning there is worsening on 3 consecutive visits after the initial regression of the ROP. So that's what you call ROP reactivation. So again, you have to choose. Either you do anti-VEGF or laser. In the product information of your ranibizumab, it is written there that you can do up to 3 intravitreal injection per eye within 6 months. These are additional strategies to prevent late detachment, even after doing your initial anti-VEGF injection. You can do treatment completion laser. Okay, so you follow up closely your patient, and then you do FA. So again, these are the recommendations from the fourth World ROP Congress. For them, because the equipment is readily available, they recommend to do EUA and FA prior to discharge and at 60 weeks PCA or postmenstrual age, okay, to see vascularity of your retina. Another strategy is that if you see persistent avascular retina, you should laser that area. So these are actually exciting times because we are at a point that paradigms are changing and we are actually looking forward to safety of your anti-VEGF, which anti-VEGF agent is the best to use for ROP treatment. Again, the optimal dose for each agent. We've seen in the past year that the updated ICROP, we want to see in the future how this would affect the treatment and follow-up protocols of our patients. So, and also, we see the potential of artificial intelligence in ROP. So all of this we are excited to see in the coming years. So in summary, laser therapy is established, safe and largely successful treatment. So your anti-VEGF agents appear less prone to cause your myopia, but the efficacy long-term and the visual outcomes and safety are not yet fully established. So these are the indications wherein you can best use your anti-VEGF as we have discussed, but with fully informed consent. So especially for your aggressive posterior ROP, your zone 1 ROP, if you have very poor visualization of your retina, can be used as an adjunct to your laser. If you have no laser equipment, you can use anti-VEGF injections. And if the infant is considered unable to tolerate a laser procedure. So again, we need further basic sciences, animal studies to see the different stages of development. We need also pharmacokinetic studies in human infants. We should have neonatologists, retina specialists, and pediopta specialists to help out and address the research gaps and need and agree on the next best trial. We also want to look out for long-term neurodevelopment and also the visual structure and function. Before ending, I would like to invite our ophthalmology colleagues to join the ROP working group in its advocacy to fight ROP blindness in the Philippines. Now, more than ever, our pediatricians are very receptive to referring babies, and they are giving back the challenge to us to come up with more ROP screeners and treaters. Because one blind child from ROP is one child too many. Thank you again and good evening.